Hi, and welcome back to Student Nurses Success, where we're going to cover some basics of neoplasia and cancer today. This is considered part two of our series on cellular injury. Remember to look in the comments section for the link to find the concept maps for this topic. Let's go ahead and get started. Here's the finished map that you will have at the end of this video. And here's our blank map, which we're actually going to start with. I've actually cut it down a little bit so that we can kind of just focus on this one side here. We should begin by clearing up some terminology for you. So let's go down here. Now, neoplasia is actually the term that means growth of tissue. The thing about neoplasia is that it may or may not be cancer. The term itself just means that tissue has been growing. Now, anaplasia is a term used when cells have lost differentiation. What we mean by that is the cells are not functioning as they were intended to function. So they do not have the same function or they do not function with the correct purpose. The thing about anaplasia is that it does indicate that the cell has turned cancerous. Now, when we talk about cancer cells, we're talking about cells that have undergone a change and they've actually lost regulatory control. They're growing erratically, they're uncoordinated in their growth, and they're basically rogue and out of control. They're not functioning properly like they're supposed to, and they're not behaving or following any rules. Now, there's some suffixes on the end of tissues that would indicate that the tissue has become cancerous. And those suffixes would be carcinoma, sarcoma, or blastoma. So if you see a diagnosis and it ends with either of these three suffixes, it has turned cancerous. For example, an adenoma is not cancerous, but an adenocarcinoma is. Last, when we talk about cancer, we talk about it in terms of remission, meaning the cancer has stopped growing, 5-year survival, which is a prediction rate of how many people with that form of cancer are still alive 5 years after diagnosis, recurrence, meaning the cancer has returned. All of those terms are used. Also, palliative means that we're not trying to cure the cancer any longer, but we're focused on maintaining quality of life and pain control. While curative means we're trying to completely eradicate the cancer. Let's go up to the top here and talk about the terms benign and malignant. So really, what's the difference between benign and malignant? Benign means that there is a growth of cells, neoplasia, but that the growth is not cancerous. Benign cells or tumors that grow have slow, controlled growth. And the cells still resemble and work like they should. They resemble the tissue and work as they should. Now, malignant means that the cells have become cancer and they have escaped apoptosis. Remember, when cells mutate or change, your body should apoptosis them, meaning that it should just kind of kill them off and get rid of them. But malignant cancer cells have escaped apoptosis. And so now these cells are out of control. These types of cells invade, they grow rapidly, they're bizarre, they do not look normal at all. They steal blood supply and nutrients from the body. And they do this so that they can keep growing. They're actually almost what we consider immortal. They'll even make their own blood supply, which is called angiogenesis. I'll just write that over here so you can see. They'll liberate toxins that destroy normal tissue. They do not contribute to the work of the host, and they do nothing useful for the body. They just steal nutrients and grow out of control. So certainly we all want to prevent cancer. First of all, age is an unmodifiable and the biggest risk factor. As our cells age, they sometimes become damaged and can mutate into cancer. Now, there are some modifiable risk factors, and these are like lifestyle types of things. These include tobacco, increased cancer risk, nutritional things can increase cancer risk, alcohol increases cancer risk, high fat diet increases cancer risk. We know that processed foods and red meats, those increase cancer risk. Sun and chemical exposures can increase cancer risk. We also know that hormones can sometimes fuel cancer. The one thing we know is that something called antioxidants, those are actually protective against cancer. So they reduce your cancer risk. Antioxidants help repair cells that have changed. So we also know there's some early warning signs. And if you look here, the word caution comes down. And there's a pretty easy way to remember. So the first is a change in bowel or bladder habits, maybe a change in your stooling patterns, a sore that does not heal, unusual bleeding, some kind of thickening or lump, maybe indigestion or difficulty swallowing, an obvious change, and maybe a sore, a wart, or a mole, or something like that, and a nagging cough, or even hoarseness. And then the last is any site-specific symptoms. If you have a tumor pressing on something, you may have some type of pain in that location. Or if you have a tumor in your kidney, you actually may have a decrease in your kidney function. Let's talk about manifestations just a little bit. How do we know we have cancer? Sometimes you'll see altered tissue integrity. And what we mean by that is the tumor or cancer cells can actually compress, erode, and cause bleeding or even necrosis to an area can cut off the blood supply and cause it to die. We also know that there's something called cancer cachexia. Often people lose weight or they become maybe a wasting appearance, wasting of their protein and muscle mass. They may become weak and tired or fatigued. And that's kind of this cancer cachexia. And sometimes we see paraneoplastic syndromes. These are collections of events that occur, maybe something we call pancytopenia. Pancytopenia is a decrease in red blood cells that causes anemia, a decrease in platelets that causes bruising or bleeding, and a decrease in white blood cells that are functioning, increasing risk of infection. We'll see maybe decreased immune response overall, maybe loss of organ function, kidneys not working, liver not working, difficulty breathing with lung cancer. And we also may see inappropriate release of hormones. We have a tumor cell that's secreting a lot of hormones that may be causing us some problems. Sometimes they can release too much catecholamines and cause high blood pressure or alter the communication in the body. Let's move over to our second half here. And let's talk about carcinogenesis, which is really the process of cancer conversion. And it's kind of a multi step process. And the first step is initiation. And during initiation, a carcinogen is applied to a cell. Now, a carcinogen is an agent that can cause a cell to maladapt or change. And we know that you need repeated exposures. One exposure to a carcinogen is probably not going to be a big deal, but multiple exposures actually will, over time, make it to the point where the cell can't repair itself. So, if the cell cannot repair from the damage of the carcinogen, it ends up mutating. And these mutations may inappropriately activate what we call proto-oncogenes or tumor suppressor genes. And actually, we're going to talk about them down here. Now, step two is promotion, and this is where the mutant cell proliferates. We know things like nutrition, either too much or not enough, can affect this. Even hormones can provide stimulus. They can actually either stimulate or promote more growth. And we know that the mutant cancer cell eventually escapes apoptosis. And if it escapes apoptosis, that means it's going to continue to multiply. Now, step three is progression. Progression is when the cell actually demonstrates what we call malignant behavior. Remember what malignant meant? It means that the growth is taking over. And it actually becomes somewhat immortal at this stage. It just keeps growing and growing and multiplying and multiplying. And at some point, we end up getting metastasis. And metastasis is when it spreads to a distant site. And so now we have cancer in more than one area. Now, you probably aren't going to notice the cancer until it gets to stage 3, the progression stage. That's when it really starts growing large enough to be detected. So let's talk about these two cancer genes here, proto-oncogenes and tumor suppressor genes. Now, proto-oncogenes turn on cell division, and we do need cells to divide. However, when a proto-oncogene is mutated, it is now called an oncogene. And oncogenes are bad. Oncogenes mean they won't stop dividing. Oncogenes overproduce. So the proto oncogene is good, but the oncogene is a mutated proto-oncogene and it's bad. The second gene I want you to know about is what we call tumor suppressor genes. They are supposed to turn off cell division, which is important. We need to stop cell division at some point. We can't have cells just dividing. Well, the problem is if it's damaged, it cannot turn off. So if we have a damaged or mutated tumor suppressor gene, it is not going to turn off and cell proliferation is uninhibited. And cells just keep dividing. Now, the BRCA1 and BRCA2 are mutated tumor suppressor genes. If you have a mutated BRCA gene, you are at a higher risk for developing certain types of cancers, such as breast or ovarian cancer. And we can test people to see if they have a mutated BRCA gene. Now, we're almost done here, so keep hanging with me. For diagnosis, our definitive diagnosis is by cell biopsy. We have to take a cell and look at it to see if it's cancerous. So we have to take a biopsy. And that's the way, oops, I'm sorry, that's not definition, it's definitive. So that's how you actually diagnose a cancer. And when we look at the cell, if it's bizarre looking or different than it should be, then we know that it's a cancerous cell. And the pathologist looks at that. For some cancers, we have a way to see if the cells are releasing enzymes or chemicals into the bloodstream, and these are tumor marker lab tests. Things like the PSA or the prostate specific antigen test. When it starts to go up, that means that the prostate gland is growing too largely, too quickly, and it may be cancerous. So they're kind of more like screening tests. Now, staging is used to identify the extent of cancer spread. We know that stages 1 or 2 means that there's no metastasis, so it's just in one site. Once we get into stages 3, 4, or 5, it is in multiple locations. And grading of the cell is done to identify the degree of anaplasia. Staging and grading help us with prognosis and treatment plans. And so our last one here is treatment. Every day we're discovering and trying new treatments. They include such things like surgery to actually remove the cancer, maybe radiation to shrink cancer tumors so that we can remove them more easily or control their growth, chemotherapy that actually kills cancer cells, and biotherapy. Biotherapy is really neat. Biotherapy uses the body's own immune system to kill off the cancer. So those are some new things on the way. We can even do stem cell transplants, which are also called bone marrow transplant or a BMT. And we'll talk about those a little bit when we talk about our what blood cell leukemia and lymphoma cancers. Oh my goodness, phew, that was quite a lot. And here's your completed map. Thanks for listening. Remember to subscribe to our channel so it can easily find more videos to help you get that great grade in pathophysiology and become that awesome nurse that you were meant to be.